to support this, we've already done a lot of work in preparation for that. So just in the terms of the healthcare benefits, we are already in the process of developing the framework for primary healthcare benefits, and that's for primary healthcare level, that's for personal services. And the DRGs, which is the disease-related groupings, which is more for a higher level of care, that is work that will be done as we go along down the line, and that is several years away. Then in terms of user and service provider management, oh sorry, I just forgot to mention healthcare benefits will also be part of the functions of the Benefits Advisory Committee, and the Benefits Advisory Committee in terms of the bill is responsible for priority setting, right? And the health technology assessments, etc., will in time move from products procurement to healthcare benefits. Then there's user and service provider management, and here it would be important to make sure that there are those linkages with our statutory councils, like your Health Professions Council, because you need to know that the person who is actually doing the prescribing is authorized to do so, and is doing so within their scope of practice. So you don't want, for example, a GP prescribing oncology medicines. Okay, it's not within his scope of practice, and that's the kind of governance system that we need to make sure that the appropriate level of care is given to the person who needs to receive it. And then there's also a lot of data analytics that we need to do to make sure that we manage our providers appropriately, because you don't want to reimburse somebody for a service that they didn't render at all. I mean, if you just think about the story that has recently made media headlines about Mediclinic, you know, so we need to have those kind of governance systems in place to make sure that we use the data appropriately, to make sure that the providers of the services are managed appropriately. Then there's the products procurement, and I'm the chief director in that particular cluster. And in this area, all the health commodities that will be used in NHI will be contracted through this particular branch. So often people get confused by the word procurement, okay? So it's not as if though the fund is actually going to go buy the medicines, but the fund will be responsible for making sure that the transversal contracts and all the SLAs, etc., that are needed to manage those contracts are in place, and the service providers will actually be responsible for buying those goods and services. And when we say services, we're talking about, like, you know, when they have to maintain machinery and those type of things. Okay? Currently, just to give you a sense of where we are with this, we do have the Master Health Product List, which is available on our Department of Health website. And if you read the bill, it will be necessary to inform the formularies that will be used by the different service providers in their health establishments. And going a step further, if you attended the Presidential Health Summit, there was a project that we're now embarking on together with SAPRA and the Pricing Committee to say, how do we then develop a medicine master data system so that we have visibility of everything that's in the chain, and all the information that we need to make appropriate decisions are available to us. Obviously, there's some information which SAPRA needs, which we would not have access to, but at least it's one system that, that will give us that kind of information. Then the digital health systems. In this space, there's a lot of support that will be needed for the HPRS, and I think in COVID we saw the value of the EVDS system in tracking how many patients actually received, or how many people received the vaccinations, etc. Here we're also busy with a proof of concept for the CUPS, the contract units for primary healthcare services. There's the Master Health Facility List, which we used very effectively during COVID as well. So for all the Section 22A15 permits for those sites that wanted to administer vaccines. We're also looking at the patient record, the single patient record, and that speaks to the portability of services, because no matter where you go, your record must be available for the service provider to be able to manage you. And then we're also looking at digital systems to address rational medicine use. And it's important in our context, especially in the area of antimicrobial resistance, right? And then there's risk and fraud management, which I think is self-explanatory. I think all of us are very aware of the risks inherent in having so much funding pooled into one place, and there is a system. So just to I mentioned healthcare benefits. The Chief Director has been appointed. User and Service Provider Management, the Chief Director has been appointed. Products procurement, I'm there. In Digital Health System, I think everybody knows Ms. Malani Volmerans. And if you don't know, like, which rock have you been living under? Okay. So just in terms of transitional arrangements, remember we said we're going to be building the system, and this is all in the bill, right? So phase 1 will be from 2023 to 2026. It will focus on health system strengthening, doing the legislation needed to support NHI, that is the regulations, etc., and all the consequential amendments that need to be made to the legislation, such as the Medicine Act, to look at pricing, etc. Establish institutions that will serve as the foundation of a fully functional fund. And then we're also looking at purchasing healthcare services for vulnerable groups. And here we're talking about children, pregnant women, the elderly, etc., and to prepare for the establishment of the fund as a 3A entity in terms of the PFMA. In this area, the Minister must establish the interim committees to advise on the implementation of NHI. So as I said, once it's signed into law, it doesn't mean that automatically everything falls away and we have NHI. There's still a lot of work. So Minister will appoint the National Tertiary Health Services Committee, a national governing body on training and development, because obviously there's different skill set that we're going to be needing to support NHI. The Ministerial Advisory on Healthcare Benefits for NHI, which will serve as a precursor for the Benefits Advisory Committee, and the MAC on Health Technology Assessment for NHI will serve as a precursor for the Health Technology Agency. The objective of phase 1 would be the establishment of the fund, migration of central hospitals managed nationally as semi-autonomous entities. And I think this is important, especially if we think of it in terms of continuity of care. Okay? Then the contracting units for primary health care at district level, the health patient registration system, which is already work in progress, accreditation process of healthcare service providers, and that's in collaboration with the Office of Health Standards Compliance, purchasing of healthcare service benefits, and that's for personal services at primary healthcare level using the CUPs, purchasing of hospital and other support services, which is an extension of access to personal services, and then the initiation of legislative reforms, as we've spoken about. Okay, then phase 2, and this is my last slide, Prof. Okay, phase 2 is it's going to take place between 2026 and 2028. Hopefully, obviously, things don't always go according to plan, so we have to manage our own expectations. But we continue with the health system strengthening, and then there's the mobilization of additional resources which we may need, and the selective contracting of health services from private providers. And the objective in phase 2 would be the establishment and operationalization of the fund as a purchaser of healthcare services through a system of mandatory prepayment, which means that when you access services at a NHI-funded institution or establishment, there is no out-of-pocket payment for the person accessing that funds. And currently, all of us sitting here have medical aids, but how much do we pay on top of the contribution we make to medical aids? So if my mother's medicine gets sent to my house, I have to stand there on the doorstep with my credit card. If there's hospitalization costs, I've got to wait until the bill comes from the hospital in addition to what the medical aid pays. So in the NHI era that we're trying to establish, that will all be a thing of the past, and we will all working collaboratively will ensure that we provide quality services to all our patients. Thank you very much.
Thank you very much, Khadija. And thanks for the promotion, Prof. It means I'm now a sub-department in healthcare. We don't have a lot of time, so I'll jump straight to it. I want to talk about aluminium. I know you said we must talk about healthcare. It was discovered around 5th or 6th BC. At that time, as an ore, it was very difficult to extract. And only around the 19th century, I think primarily 3 scientists, and they're in different countries, refined methods of refining. Now, in the beginning, it was quite expensive, actually more expensive than gold. and other precious metals. And it was only when it found relevance in production of other things that it became more affordable. The first time that it was used widely was during World War I, when it became used for strategic reasons. Initially, they used it for everything: fabrics, money, glassware, and then it started making its way into bombs, into airplanes, into other things. As a result, they deployed these additional methods of production, and it became more available and it became cheaper. Now, what was interesting is that during World War II, they started running out of stuff. As a result, the war effort was undermined or could have been compromised. And then we saw that it contributing to this demand of aluminium. And they brought literally their pots and pans, and they ripped off their wrought iron establishments around their houses, etc., and contributed to the war effort to make sure that the army and those who were running the war had enough armaments to fight the enemy. Now, healthcare and health are the modern day aluminium in our current day war effort. As a result, healthcare reform needs to be a really inclusive process, very much like when households sacrifice their hard-earned money, sometimes literally, and the pots and pans in their households to contribute to the effort. The current process and envisaged bill is inclusive only as far as service provision is concerned. But that undermines what we could possibly contribute as a private sector community to this war effort. Our pots and plans also includes private sector funding. And this is voluntary, and it's after tax money. I know, Khadija, you spoke about the wastage in the private sector, but these voluntary contributions that people pay for their own health care. And this is just over 4 million South Africans that are currently doing this. But it's significant. More than 4% of the GDP actually comes from voluntary contributions into healthcare services. It's the same level, incidentally, as what the mining sector contributes to this country. So it's not a small change. The private sector healthcare industry employs more than 360 men and women with various expertise, many of which are not available in the state, and many of which will not be absorbable through this process. So it will be a wastage if we disregard what is available in the country as it is. So you see, a lot of pots and plans are going to be needed to improve our service provision, more than just the passage of the bill. We have to find, one, teach a lot more health practitioners and professionals than we currently have, and employ them, because we know that, and I'm sure Dr. Ndlovu will tell you about the plight of many practitioners who are sitting at home while we're struggling with deployment of their much needed services. I mean, the Human Resource for Health 2030 report or strategy report indicates that we need at least 97,000 healthcare professionals by 2025 to harmonize service provision within the provinces. Secondly, we have to refurbish and build new healthcare facilities and make sure that all of them fulfill the requirements of the ideal clinic model, more than the 60% or less that currently fulfill this, as is currently the case. Thirdly, we have to be able to improve and maintain access to essential medicines and vaccines, and be able to manage their supply to the various facilities. We also have to lead and govern our systems and sectors with competence and integrity. This means we have to decisively deal with the scourges of maladministration, corruption, and these are rampant in many of our institutions. And we have to be able to have able technology or technological system to manage information and data accurately and responsibly. This will allow us to plan and respond to the health needs of our communities with agility and accuracy. The implementation of the universal health coverage is too important to fail. And it's important that everybody who can contribute meaningfully should be allowed to at the onset, and not only when things don't work out. We have access to templates that we can use, whether you're looking at the WHO or wherever, and a lot of these are also in our institutions, in the private sector that I alluded to. And we have fortunately also acquired some experience of working together on large healthcare projects. The COVID-19 and its vaccines rollout are a case in point. So if you go back to my aluminum story, participating in the war effort in World War II often required young men and women to literally put their lives on the line. While our effort doesn't involve putting our lives on the line in putting it together, we will, however, pay with our lives if we don't get things right. It is that important. Thank you very much, Prof.
Good afternoon, everyone. My name is Lauren Pretorius, and I'm the CEO of Campaigning for Cancer Patient Advocacy Group. I get asked to speak about patients and NHI a lot, and a lot of the time I get asked around a BRI as well, questions that I realize that there are very few people that have read the regulation. At the end of the day, I think that universal health care is something that not one of us in this room would say that there's fault in. That we would all, if we had to sit down and say, fundamentally, as a human being, should we all have access to health care? Should we have equal access to health care? As human beings, should it be a right? Each one of us would agree with that. The famed anthropologist Margaret Mead was asked, when did people start to organize into society, and when did she see that we became civilized? When were people civilization? They were asked. They said, was it the invention of the first government? Was it And her answer was, when they found someone with a healed, broken leg. Because someone cared for that individual. That's when we stepped into being the human that we are. And that's something that we have to remember as we talk about and take this road down NHI, is that there was someone that cared for that person with a broken leg. They brought them food, they cared for them, they made sure in their very primitive ways that that person could survive. And in order to do this, we have to start re-looking at a few things. Number one is including patients and citizens in health decision-making, and not individual health decision-making, policy decision-making. Allowing them to be on the committees. And while they might not be as illustrious as some of the lawyers and the doctors, they are the people that care for the broken leg. They care for the mother and the brother and the daughter and the son that is sick. Or they are the brother and the mother and the daughter, the son that's sick. And we can't lose track of that. The second thing that we have to remember is that people have ideals and principles when it comes to politics. But those ideals and principles can get people killed. We've seen it throughout history. And are the ideals and principles that we are holding on to, we have to ask ourselves through every step of the way of this, are the ideals and principles I am holding on to getting people killed? Are people dying because of my ideals and principles that I'm not willing to give up in this discussion? And that goes from everyone. It comes from public, from private, from politics, from business, from patients. The third thing that we have to look at is that we have to take a serious admission in South Africa to say there are a group of patients in this country that we do not look after. We have looked for many years, over the last 30 years, at only certain disease areas. And while we've done really well in that, we've only focused on those disease areas. There are patients with other disease areas that are dying daily because of that. Patients with NCDs, with cancers, with genetic diseases that are dying for this because we haven't paid enough attention to those disease areas. And the last one is that we ask ourselves to take responsibility. Because as you said, there are people dying for this. And if we can say, truly, each one of us say, in our responsibility, are we happy with the health care that all South Africans are providing and are receiving currently at this point? I can tell you the answer is no. So how do we change that? And we each have to take responsibility for that, as patients, as doctors, as products, as government. Because if we don't, the ideals of universal health care and the resulting coverage that is developed on what a patient can do become just that, ideals. We have to have hard discussions with ourselves on what we can afford and ways of financing this. Because you can give anyone as many rights in the world. But if there's not a way to finance those rights or make sure that they have access to those rights, it's as if you didn't give them the rights. And currently some of our patients in South Africa sit with that. So my call today, my one thing, Prof. Chetty, is ask yourself, have I changed my mindset? Have I changed the way I think of things enough to be the person that cared for the person with the broken leg? Thank you very much.
Thanks, Lauren. Good morning, everyone. I will start where you ended, around taking a really serious look into what we do. And what we do not do well is listen to each other. Now, the NHI bill and universal healthcare coverage discussion has always centered around the disparities in healthcare access, in health outcomes, as if we disagree or as if we do not know. Now, this is the system we were born into. We know it well. We grew up in it, we worked in it, and some of us had the privilege to be taught in it. So we know how it is like to sit in those benches, King Edward, Eddington, and Clarewood. We know that. So we cannot be taught about the system as if we do not know it. And we know also the problems, the challenges, and the inefficiencies and the cost that sit in the private sector. The 4 million people is not enough. So I do think that just to set the tone, that the question of universal healthcare coverage or the lecturing that happens as if we are saying no to what we agree on is not on. And part of it requires some really deep sitting down, engaging, and listening to each other. And so some and other doctors that we are affiliated to, as they will always say, the purpose and what the bill seeks to do is what we stand behind. But the question we ask ourselves is it the right vehicle? And what Dr. Machudi did is talking about healthcare strengthening framework. And we say there is a whole lot that we need to do. One being human resources for health. We sit with doctors that are not employed. We can't train enough. The PESEP study done a few years ago said there were about 10,000 specialists in this country serving both sectors. Morgan would know that there are about 15,000 odd GPs. So we're sitting with the doctors that are about 25,000 in this country. And we have some, that are not employed. We have shortage of nurses, shortage of pharmacists, and it abounds. And those are some of the areas that we need to keep our focus on. We sit with built infrastructure that needs focusing on the crumbling of our hospitals is just not acceptable. Partly because we come from there. Our families, they are on those benches as we speak. And so we want that also to be fixed. Access to essential medicines and drugs and vaccines is important, and that also is what we're talking to. And so, as we speak about NHI and talk about leadership and governance, and what we've seen, Khadija mentioned Mediclinic, and we've seen others as well, including Tembisa and others. You know. So there's a lot that needs to happen in fixing our system and in strengthening our system. And the money bill is one way. So there has to be parallel streams that ensures that the healthcare strengthening happens and not just fixing and pulling the money, because that always gets us in trouble, and we've learned it too well in this country. And so in listening to each other, there are centers of expertise and excellence that sit in both sectors, and some in private sector. So we talk of single purchaser, single payer, and Dr. Mutudi will tell you that there's some systems that don't need to be rebuilt because they already exist. We could just talk of DRGs, some talk DEGs. That intelligence sits somewhere today, and the department does not need to redo that. We can create efficiencies if we sit together and listen to each other to make sure that the system in which benefits us and those that we love is a system that is stronger, a system that where we all listen to each other and not just preach to each other. And therefore, it is in our interest to fix our healthcare system. We were talking at dinner yesterday and said for most of us that are sitting here in grey, got nowhere else to go. This is it. South Africa is home, so we're not going to go anywhere. And this is in our best interest to fix it. And we need the department to be able to listen and hear us as well. Thanks.
Good afternoon. I'm still harassed. When the Minister of Higher Education and Science and Innovation addressed earlier today, he talked about the 2021-2031 cadre plan, and that's about supporting innovation in healthcare. And that talks to a great extent about what members of my association do, talks to us, so I won't say any more about that. But that's where IPASA, the Innovative Pharmaceutical Association of South Africa, is located. Oh, there's someone doing the slides. You can go to the next slide, please. I've taken note of the points that Jamaica. And I was pleasantly surprised to find that in the next 5, possibly 6 years, there will be a deliberate part of the NHI implementation that will be looking at the health systems. And as Morgan requested, if there's one point I would like to emphasize, actually, the first one is that let's focus on health system strengthening in the next 5 to 7 years until we are certain that our health system, consisting of both the public and the private sectors, is strong enough to be the recipient of the innovation that's going to be required to lead us forward into the era of health systems which are based on innovation. The point that I should have made at the beginning is that my association is fully supportive of universal health coverage. We are committed to it, so there should be no doubt about it. And we believe that there are just some challenges that we need to focus on. And those challenges are around finding the right balance between access, equity, affordability, and sustainability. And the only way we can achieve that balance is by ensuring that we continue to have very robust discussions, such as the one that we are having now, where in everything that we say or listen to, we recognize the system or the principles of give and take. And if we can do that, if we can accept that we have lots of stakeholders in the healthcare system, and when the majority of them make one point, surely they want to be listened to. If we do that, I think the next 5 to 8 years as we work on health systems strengthening will be key to ensuring that we have kind of universal healthcare coverage that we really want. And for me, that's the other point. I must just emphasize that we saw during the pandemic, COVID-19, how the private healthcare sector worked very closely with the Department of Health. And the private sector has made it clear on a number of occasions that they have the will to work together with government in health system strengthening. And that also means revisiting the human resources strategy of the Department of Health that's been developed quite some time ago. Those are the 2 principles that I would say we want to support. Now, coming specifically from my side, we should ensure a sustainable medicines industry. And our plea is for the National Health Insurance Fund to procure innovative medicines, because this is the only way we're going to ensure that we have a continuous pipeline of generic medicines. And we are the first ones to pick on any new innovations that get onto the market. That's the only way we can achieve that. The last point I would like to make is, it's not the last point, but there are quite a number of points that I wanted to make. But just coming to the pricing of medicines, we've talked a lot about principles around alternative reimbursement models. Our plea is for a flexible hybrid system of medicines pricing and procurement to be accepted. And what that means is that we have a system that, while it recognizes that when innovative medicines come onto the market, they might be too expensive for all sectors of our population to have access to. But if you have a differentiated system of pricing, then you will ensure that the health system becomes responsive to the various sectors of the population, and in that way, everybody has the same kind of access to all the medicines, regardless of how much they have in their pockets. If those points can be recognized as we continue talking in the next few years, then I think we'll be on our way to ensuring that we keep innovation at the basis of whatever we want to do to strengthen our healthcare system. Thank you. Prof. Momo.
Thank you to all speakers. When you listen to people of this caliber, you start scribbling on notes. Then you can't find the notes. So let me just say a few points before we take questions. The first thing is, everybody said this, and Lauren said it best. We need to listen. People have arguments, people have decisions, people live in the system. As Claude said, we were born into the system. Right? We work through the system, we live through the system. So let's listen to our experiences are real. So are we listening? Is government listening? Lawrence is a very important question. You're going to have a mindset change. Now, I have been involved in healthcare. It doesn't look like I was, but I was involved for like 50 years. Right? And I've been around for more than many people. And I can tell you something. I worked with a number of different people in government here. Government doesn't listen. They come to the meeting, they've got their minds made up what they want to, they've got a political kind of agenda. I think we have to move away from that, guys, if you want to move forward. That's what the message that came out clear. We need to be constructive, look into ourselves first. Doesn't mean that you're getting a salary from government, that you're going to think like that. You're going to find how you make this change. Dr. Mutuli spoke about health system strengthening. Yeah, our horizontal platform is derelict, absolutely derelict. We mustn't look at what USAID did and what the World Bank did. They did what we call vertical programs that work very well, disease-specific, project-specific, but they work off our horizontal platform. When they left, our platform worked worse. That platform was facilities, under-resourced, underfunded, under-equipped. Let's not fool ourselves. Right? We can't give quality, safe healthcare with the present resources. That's what I said initially. That's what universal healthcare coverage is. You've got to have access to the qualification. Do we have human resources to help? No, we don't. We have what's been calculated to be 1.5 per 10,000. The WHO threshold for universal healthcare is 4.5 per 10,000. So we're far away from that. So what are we going to do? We can't go produce new medical students tomorrow and doctors in 7 years. We're going to wait for 7 years. What we're going to do, we're going to take people of lower level now, we're not doing it, and upskill them. So that these people at a lower level can start doing more work and free the doctors to work at the top of the license. Free the health professional to work. I don't think a health professional who's qualified for 7 years and been in practice for 6 or 7 years more should be taking blood pressures and doing little things. That should be done by other people. That should be screened. He must be making decisive decisions. We need to get on that very quick, and we can't. The other issue that we need to understand is, and I'm making a big point that came out of this meeting, a spend on health is not an expenditure. Please take this message back. It's not an expenditure, it's an investment. When we spend on health, it's an investment. We must say, oh, we're spending too much on health. If we don't have it, we've got to spend more. Secondly, South Africa as well, we have a problem in the sense we're spending about 8.5% of our GDP on health. We should be spending 5.5%. So we're spending 3% more. We don't have universal healthcare, we don't have quality healthcare, we don't have very safe healthcare. So we have problems. Also, we are deficient from the Abuja Declaration and the Standard Declaration, which said every country in Africa should spend at least 15% of its GDP on health. Right? The best we've got so far is 6.7%, or if it's South Africa to the mix, 8%. So we're totally deficient. So people
The arguments that my colleagues brought up are very rational arguments. We're going to reframe our thinking and rethink and probably re-engineer the future by a realistic commitment that we want the future to change. And I'm going to say something here, there's no press reporters here, so I can say it, they won't quote me tomorrow. You know, this mustn't be in preparation for the 2024 election. This whole hype on universal healthcare, it must be for the care of the people of this country, irrespective of what happens in 2024. In fact, whichever political party comes into power, they can't dissociate from the fact that we have a moral obligation. So people are just trying to cover a little bit, so we don't have time. We have lots of information here that I can share with you, but we really don't have the time. So I think I'm trying to capture this so that we can be more sensitized, and I'll open this to questions from the audience, and let's see what the audience has to say.
Thank you so much for the awesome summer. And I think I will really add a lot onto the importance of government listening. And when one thinks of government listening, you also want to look at the other industries, how they function, when optimizing their processes, when re-engineering, their processes and systems. So if you think of the engineers, for example, when they use process engineers, they use methods such as Lean Sigma 6 and the failure mode and effect analysis, for example. When you listen to the change managers driving adoption, which is something that will be key for the NHI to be implemented, there is a strong reliance on talking to experts, talking to people that are working in that space, listening to them, getting, incorporating their experiences in the system that one is re-engineering. And I think that is something that needs to be highlighted. It's something that needs to be done because no one will be able to assist and give all the information that is required to re-engineer our healthcare system better than doctors, better than nurses, better than pharmacists, and all the other healthcare workers that are involved. So it is very important for government to listen and to use evidence that comes from medical practice, from different healthcare practitioners on the re-engineering system. Thank you.
Okay. I'll come back down there. Just to say, yeah, that's very important. I think this all goes back to the fact that the narrative must be positive and we need to talk. And I want to leave one message here before I go to the next question. And think about it, Claude, I'll come back to you on this. Is there anything like a discussion on? Is there a correct time? Is there a right time for us to introduce universal healthcare? People say it's a wrong time. When is the right time? So think about that. The other thing I was going to say is that, the message to government, and I'm sure it comes from you, someone, all of us, is that, listen to us, we want to work with you. We want to find solutions. You're not here to fight the system, right? It's your relative and my relative are still going to get the same kind of care. So can we just make sure that we're committed honestly to it?
Thank you, Prof. What I'd like to put across to the department is what Prof has just concluded on. As the private sector, we have a vested interest as government does, and we wish that the government can be aware that we are interested in incorporating solutions for the healthcare that, for the universal healthcare that we embrace. So when we knock on doors to contribute, we wish that the government can recognize the sincerity of our endeavors, that it is not for any other reason that we are wanting to be involved in the healthcare system strengthening and so on. is simply for the realization of the objective that we all embrace. Thank you so much.
So I see there's another session soon, so I don't want to cut this discussion off from the legs so that we all walk on crutches. I just want to take this into the next step. So ask Claude to tell us if there is, I think because everyone says, why are you implementing it? Right? For me, in some people's lives, they urgency, they don't get any health care. In some people's lives, they're okay. So Claude, what's your view?
Thank you, Prof. I do think that one can put a time step. We sit here today with people at Prince M, sitting and waiting for their cataracts, sitting in Limpopo with people waiting for their knee replacement surgeries, and there are opportunities and capacity in the private sector. So there's no time step. However, we must definitely be able to say what is it that we want to do and what is the roadmap and how do we get everybody along on the journey. Because for me, that's what it is that we all walk the journey together as we try and fix the healthcare system. I do not think there's actually a time step, but we must walk the journey together. And part of it, as all has been said again, Prof, must sit, close the doors and say, Nicholas, we've heard about the 50% of food. Let's move past it. How do we get it sorted?
Yes. I just want to summarize what Claude is saying for the take-home message. I think the process is going to be iterative. Right? We can't tomorrow say we've got universal health care for everybody and no matter. It can't. We're going to start with the indigent, people who need health care. Let's build this up. And let us, as a community, work to the next step, the next step, the next step. This idea of everybody looking at universal health care at the same time. Even in Taiwan, and in South Korea, where they introduced it, people are still paying for what it's not free. It's free for certain people, certain things. The best example, all of you should read, if you ever have the time, is to Google what is happening in Indonesia. 17,000 islands, 261 million people, speaking 700 and somewhat languages. 83% of them have got universal health care, or some health care. How do they do it? They sit around the table and they embrace the message. So, one thing I'll tell you before I go to the next speaker is the future discussion. You cannot leave the private sector out of it. The private sector has got resources, it's got expertise, it's got experience. We need to harness the resources. The resources belong to this country. Right? So if we don't take the private sector as part of our partners, this is going to be a total failure. And I made one point. We have only one chance, guys, to get universal health care. Don't mess it up. Because we live in a very unforgiving world. Right?
Thanks very much. Very interesting discussion. A number of points have been raised. Discussion is not but I think just to highlight 2 points. I think what we're seeing here is a situation where we are combining an academic education into the physical context. And I think this is what has been raised a lot. So, as government goes ahead with the discussion on the HR, let's have an area where we look at academics, frameworks, funding, and legislating things which is separate to outside of civil society discussion, because that's where I think a lot of confusion is taking place. Secondly, is this about a bit of a challenge I have with phasing in the NHI. How can it so, in your own words, domination? So you can't say the poor, because the impact of health delivery on the poor involves a whole frame of components. You can't say this is not for the poor, so we're not going to do this part because, or this is not for this people with disabilities. So I mean, yeah, there's a lot to talk about. I think we can just have the academic part of it and take it up with the civil discussion that we have to understand. When you phase it in, we actually are currently in the universal South African system. Anyway, I think the difference is that you can't say tomorrow we're going to be universal health coverage. We already are in a situation where everybody has access to health care. And I think the term about voluntary versus non-voluntary. Voluntary is a non-choice environment. It's actually not voluntary because you're not saying to somebody, it's your choice to take up this coverage. That's an unfair statement to make because if they don't have an alternative to that, then what do you say to them? Say they don't give you the choice or you have an opportunity to they don't have an opportunity. So yeah, sorry, one thing will on and on.
I think that's another question that we've been saying, that if a person is in a low or middle income country with no options, right, and we see this with some of the insurance products, it doesn't mean that person, because you're paying a little bit, but that's what you're paying the 50 for, they should get low quality health care. At the end of the day, the rich people who are putting in money should be subsidizing this. So we can't say we have a different formula for you and different benefits for you. This is ridiculous, absolutely ridiculous. Everybody at the end of the day should get good health care. So when I said incremental, what I meant, it's doable. Right? If you're going to look at saying everybody has enough money to get the whole country in, then there's an argument and this debate can go on for another 2 decades. But we need to get it in. Can you say something?
Thank you, Prof. So just to summarize some of the discussions that I'm taking back from this side, and before I do that, I just want to assure the room that when I showed you the administration that's currently in the department in terms of the branch, it is going on to what Prof said about election 2024. No one in that administration belongs to a political party. So we there as technocrats to do our jobs. So just want to give that kind of assurance. Second assurance that I wanted to give was that we've been busy with health system strengthening for a long time. So it's not as if though when the Act is signed into law that we will start with health system strengthening. We've already started on that process. And it's just about strengthening that particular area of work, especially as it relates to the human resources for health. We are busy with task shifting, as they call it, for the doctors, nurses, pharmacists, etc. There are big projects around infrastructure, but we know that when there's a lot of money involved, then you get the people coming out of the woodwork. That is something that is being addressed as well. What I'm getting back is that people feel the need to be heard, and that's something that I will put in my report to my senior management. And I'm also taking back is that there's a lot of commitment by the people in the room to co-create, collaborate in developing the systems for NHI. And there's a lot of opportunity that exists in the private sector, which public sector can be huge on. And that is the idea behind establishing the NHI. Thank you, Prof.
Yeah, unfortunately, I think the good thing about it is that everything that was said is positive. And we're interested in the benefit of the patient. I'm going to ask Bala to make the last statement and challenge I've given him. You should tell us what idea do they have in place. South Africa is a net importer of medicines. And the majority of the medicines we import, so forex is leaving this country. You don't have money, but you're going to spend money to buy medicines. So what's the kind of thinking going forward, and how soon will we be able to be less dependent on foreign imports?
Certain government departments, such as the Department of the DTNC and DSI, Department of Science and Innovation, have lots of projects and programs that intend to be supportive of local production of medicines. And taking the cue from those initiatives by those departments, the Innovative Pharmaceutical Association of South Africa has concluded a memorandum of understanding with the Department of Science and Innovation and the South African Medical Research Council. The main objective of which is to support the manufacturing of innovative medicines within South Africa. We believe that South Africa does have the capabilities, does have the need, in fact, to produce its own vaccines, to produce its own innovative medicines, and we do have the scientists in this country to support them. And that's an MOU that we have entered into, and we believe that with time, those objectives of those two departments will be realized.
Thank you, Brother. I want to just say one thing about this, about medicines, etc. I think we should have an African solution in Africa, meaning that if a medicine is sort of passed and used internationally, it comes to Africa, each country then has to go back to its statutory body. It's just a waste of money and time. We should have a single body to validate these medicines instead of repeating it and so using our resources again. So the message today is that I think it's a good debate. We managed to focus on other things. You've got to be honest when you debate NHI. Say what's on your mind because you're looking for answers. Right? We can't just keep throwing things under the carpet. It doesn't work. So my point is not to you, but to everybody, and I can speak for everyone here, is that every one of us here supports the concept of universal health coverage. There's no debate on that. I don't think anybody would say no. There are, unfortunately, due to the narrative, we hear different ministers and different people saying different things. This narrative is creating uncertainty, it's creating complexities, and it's creating a lot of challenges. So if we can go past those and not harbor and spend our lives looking at challenges, but looking at what opportunities there are where we both can work together, using those opportunities to build a system, we would. So the message is, yes, we support it, but I think the final thought is we want to be part of the solution. So I want to thank you all for being here and for participating. Thank the organizers for being together. I just want to say next time we do this, the NHI will be a full day. Not at all. Thank you very much, everybody.